So happy to have you with us. Thank you to our hosts this evening, the folks at Montgomery County Department of Health and Human Services. We actually have Neda Sultani with us on the line. So if anyone has any questions about their work, she's here with us tonight. This program is being recorded. However, we're so glad you're here with us live because we want to hear from you. Please submit your questions throughout the program using either the Q&A box or the chat feature. Judy Hirsch is with us as well. She's our Director of Community Engagement, and she and I will be checking the chat and things as we go on the evening, and make sure that any questions you have, we'll try to get those answered as we go on. Any questions, by the way, as far as that recording goes, any questions that you ask will not be recorded or seen on the recording. Those will all be private to the panelists and myself. When this program ends, you'll have an opportunity to take a survey that'll pop up automatically. We love to hear from you. We really do appreciate your feedback. This is the follow-up page, conversation.zone/opioids. Which is pretty much what we're going to be talking about tonight and lots of other things around it. But that's where you'll find some information. The recording of this program will be there. Any slide presentations that are shown will be there and so on. So you don't have to take screenshots or anything. We'll make sure to provide you with all of that. I always like to remind folks that we have these really terrific support groups taking place throughout the region. Many of them are on Zoom right now. Some are taking place in person, but Parent Partnership has expanded pretty dramatically this year. We now have 15 meetings taking place every week, Sunday through Thursday. You can see this link on our website where the Parent Partnership calendar is, has all these meetings that are in green are actually happening on Zoom. So, you know, we don't have geography anymore. We can just meet as we are tonight with some folks from out of state or across the state. But we hope you'll check this out. The purple buttons are in-person meetings. There's one hybrid, but these are just parents supporting other parents. We've all had some kind of challenge, either as a parent, grandparent, caregiver of some kind, of someone with a substance use disorder. I'm the parent of someone in recovery. These meetings mean the world to me, and I really, truly don't know where I'd be without them. So I'm so grateful for this panel tonight while we have some really terrific folks with us. We're going to get started with Dr. Greg Hobelman. I'm going to stop sharing my screen. There we go. And Dr. Hobelman is the joint CEO at Ashley Treatment in Maryland. You want to tell us a little bit more about your background? I could read your bio, but I think it's so much better if we hear from you what your passion is, and you're such a friend to us for being here.
Yeah, thanks. So my background is in anesthesiology and pain management. I'm in recovery myself, so I've been sober for a little over 10 years now. And after I got sober, I went back to do a residency in psychiatry, and from there went to work at Ashley Addiction Treatment, where I still remain. So I'm primarily, act as an addiction psychiatrist. But we also have a pain program, so I'm very active and interested, in continuing to learn and treat patients with pain. And so with that, tonight, there's so much we could talk about when it comes to pain and opioids and pain recovery. But we'll try to touch on a few brief things in the short time that we have. Some basics about pain. Really what we're talking about here is chronic debilitating pain, and understand how pain affects individuals, and then how they can be treated through a comprehensive recovery program, rather than just sort of manage it or treat it with pills or procedures. So, sorry, just get the computer set. So, first thing is the prevalence of pain is in the United States is massive. I think it's underestimated and people underappreciated, but it is the number one reason that patients present to their physician, chronic back pain being the actual number one reason. And about 100 million adults actually suffer with some sort of chronic pain. And if you think about that number, that's over a third of patients in the United States wake up with some sort of pain. Now, most of them manage their pain very well, but a small but significant percentage have chronic and debilitating pain and the healthcare costs associated with that. The last estimate was in 2010, but we are talking 5.5 to 6.5 billion, 550 to 650 billion dollars in costs, and the number's probably closer to $1 trillion now. The history of pain and pain management is interesting. I love this quote. Pain is the oldest medical problem and the universal affliction of mankind, yet it has been little understood in physiology until very recently. And that's true. We don't have a strong understanding of pain. We know more about acute pain, but chronic pain is somewhat of a mystery to us. We understand some of the structures and how it works a little bit, but there's a lot that we have left to learn. And pain has been seen very differently in different societies over time as well. And some cultures really valued pain. They saw it as part of the healing process. There's a spiritual component to it, and they welcomed pain. We do not live in that world right now. We live in a world here in the United States where we want to get rid of all pain. And that did create some problems for us, as we'll review in a little bit. But where we are now is trying to eliminate as much pain as we possibly can. And so we'll talk a little bit about how we can at least decrease the suffering, and because it really is impossible to eliminate pain. So what is pain? I do actually love this 1968 definition. Pain is whatever the experiencing person says it is, existing whenever he or she says it does. And it just speaks to the nature of pain. It's a subjective experience. We should be taking pain complaints seriously, and certainly try to get an understanding of how that person is suffering from it. But we don't have any way of objectively measuring pain. I do like the 1979 definition here. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. And the reason I like that, and it's commonly used still, is because it's not just a sensory experience. It's very much an emotional experience. And it's not necessarily associated with actual tissue damage. There could be potential tissue damage, and very often there's no etiology that we can find for chronic pain. There's an important distinction to be made between acute and chronic pain. So acute pain is the pain that results from some sort of injury, whether it's a surgery or an actual injury. Any sort of tissue damage causes pain, and the pain exists until that tissue is healed. And there's a point to it. The point is to protect that area of your body, and it makes sense, and it goes away. Chronic pain, on the other hand, is pain that persists beyond the tissue healing. And we don't really have any understanding of why or what purpose that would serve. So really, it doesn't serve much of a purpose at all, and we don't understand the pathophysiology of it very well. We typically divide that type of cancer and that type of pain into cancer or terminal pain and non-cancer or non-terminal pain. Sometimes that non-cancer, non-terminal pain is called benign pain. It's certainly not benign, but it's called benign pain because it won't kill you, but it does create, quite a bit of misery. And then there's a process called chronification, which is when acute pain turns into chronic pain. And there's some pretty interesting concepts here. And I think getting an understanding of this, helps us to understand a little bit more about the nature of chronic pain. So the nervous system changes, it learns and adapts. That's called neuroplasticity. And that neuroplasticity is occurring when pain is transforming into chronic pain. It occurs in several domains: perception, cognition, emotion, attention, and so forth. But a really important part is that the pain processing shifts from pain pathways to emotional pathways. So really important, the pain processing shifts from pain pathways to emotional pathways. So the emotional pathways play a large role in chronic pain. It's a very emotional experience. And what occurs over time is that the threshold for the pain is then, the threshold is reduced and the pain is amplified. So how do we get here with opioids? I'm going to review this very quickly. It's an incredibly interesting story. Most of you have probably heard of it or understand some of it. There's been a ton, of books written about this. There's a lot on TV. You can watch Dope Sick now, Empire of Pain, a lot of great things that describe the story. But just in a few quick words, pain pain was recognized as a serious problem in the 90s. Now, throughout most of the 20th century, opioids were not prescribed for pain outside of a hospital because they understood the potential for substance abuse and addictive problems, but also for other reasons, because of some laws and so forth from the early century. But in any case, they just weren't really prescribed. When they were looking for better treatments for pain and paying more attention to pain, one of the things that occurred was they started to utilize opioids as more of a first, second line agent for pain. And that became something that was widely acceptable. And there's a whole backstory to it, but I think providers were looking for some sort of a solution. And then some pretty sketchy stuff occurred as well. The beginning of high dose, long acting opioids came to be. And with that, there followed a heroin market and so forth. But there's a massive increase in prescribed opioids. And a big part of creating addictive problems is access. And when you increase access, you are going to increase addiction to that substance. And so that did occur. And with that, the people who were selling heroin and so forth followed that. And so when the prescribed opioids were decreased over time, you saw an increased use of heroin. And then with an increased use of heroin, you saw increased overdose, particularly with fentanyl. I know it's a very, very brief description, and there's a lot to that story, but that's sort of how it has occurred. And something interesting to see. So this is drugs involved in overdose deaths. And a couple of lines that I want to point out. If you look at this first look at the light green line, that is prescribed opioids. So from 1999, as we prescribed more and more opioids, the overdose deaths increased. When there was a little bit of a squeeze and a drive to decrease the prescribing of opioids, there actually was a dip in overdose deaths here, and then a slow increase again. And we still have a lot of opioids being prescribed, but it has been decreased. If you look here at the darker green line, that's overdose deaths from heroin, and that remained quite stable for quite a long time. When the supply, so to speak, of prescribed opioids was decreased or limited, people tended to switch to heroin. Heroin's more potent. It's not controlled in any way. People don't really know what they're going to get. So you have an increase in overdose deaths from heroin arising because of that around the same time. And the most striking thing to see is this blue line, of course. And this is when fentanyl came on the scene. And fentanyl is much more potent than any prescribed opioid, or it is a prescribed opioid in some cases, but the doses that they're using, it's a more potent opioid. And when that came on the market in 2013, you had a just massive increase in overdose deaths. And that's what we're seeing right now. We're seeing overdose deaths primarily from fentanyl. And people who think they're taking OxyContin, people who think they're taking heroin are actually taking fentanyl in most cases right now. And the reason that is because it's a more potent substance. It's a smaller volume of substance. It's easier to transport. It's easier, so it's more lucrative on the black market. Now, going back to chronic pain, and again, there's only a small percentage, but it's a very significant percentage of people that do suffer from chronic pain and from debilitating chronic pain. And what occurs is that it's not just a physical experience, as I've noted before, but it's truly a physical, emotional, cognitive, and a spiritual experience. So, of course, the physical piece we understand, but the emotional piece, as I had noted, the pain processing actually switches from physical to emotional, and the areas of brain that process the psychological pain are activated with physical pain. The number one predictor for an acute pain process transforming into a chronic pain is the emotional response to that pain. So if somebody has a poor emotional response, they're more likely to end up with a chronic pain condition. And then with that, you see this potentiation of other potential disorders, or you see a new onset of certain psychiatric symptoms like depression, anxiety, sleep disturbance, PTSD, of course, substance abuse. And sometimes you see these personality vulnerabilities, so to speak, come alive during those times of distress. In terms of cognition, and that's the thinking piece, the pain and cognition share neural substrates, and they interact reciprocally. So pain processing interferes with cognitive processes and vice versa. So there are clear cognitive deficits in somebody suffering with chronic pain, things like decreased concentration, attentiveness, difficulty making decisions, being forgetful, and so forth. But even more important than that, from a cognitive standpoint, is that people tend to think about their chronic pain. They might be thinking about solutions to it, but the chronic pain is taking up a very large part of the brain. And it's something we very much see in substance use disorders as well. People become very preoccupied with the substance. Same thing happens with a chronic pain condition. And then from a spiritual perspective, people always, question what exactly is spirituality and stuff. And what we're talking about here is, the spiritual nature is just the core of a person's identity, who they are, and their motivation for life. And so they start thinking about different questions, why me? What could let this happen? People don't understand, become isolated, and so forth. So I think this is probably the most important slide to help understand what occurs in chronic pain. And this is sort of the ongoing cycle of pain. Not all of this occurs in everybody, but it tends to occur. Most of these things tend to occur in people as they continue to suffer with chronic pain. So you start with persistent pain, and over time, you lose some ability to function. And that can be to varying degrees. But when you lose function, if you are somebody who's used to riding your bike to work every day and you can no longer do that, that affects your function. And then that can go on and on, affecting your function to greater or lesser amounts. But when that occurs, people have a lower perceived quality of life. And it actually is potentially a very much lower quality of life because they're not able to do what they once did. And that in and of itself, whether opioids are involved or not, tends to diminish the capacity to tolerate that pain. So your threshold for tolerating pain goes down and you start to suffer more. Pain then becomes the primary focus of life. And it's the thing that you're thinking about. That's that cognitive piece. With that comes a lost sense of self-efficacy or a decreased sense of self-efficacy, some feelings of victimization and catastrophizing and so forth. And with that, family and social roles change. People tend to become isolated. Their roles in what they typically did, the things that where they identified, if they identified as, a husband, a wife, a father, a mother, a worker to some degree, someone who, skis, walks, bikes, whatever it might be, those tend to diminish. And the primary identity of that person becomes a person with chronic pain. And then the worsening emotional state follows, and this cycle continues and continues. Now, what's really important to know is that role of someone becoming the pain patient or having that as their primary identity and being part of the cycle is very insidious. There's no part in any person who wants that to occur, and there should be no blame associated with its evolution. And it does tend to create some difficulties with roles in the family, with roles socially, roles with providers. So we really do want to approach these people with a lot of empathy. And once they understand what's happening, they tend to automatically start thinking about it in a different way. So when we're talking about how to change that paradigm of pain recovery, from pain management to pain recovery, it really is a change, because what we've typically done is we've treated the physical aspects of the pain. Every now and then someone enters some sort of cognitive behavioral therapy, but it's actually quite rare that people are doing that in the outpatient on an outpatient basis. And then there are a variety of procedures. When those things aren't working, we really do have to look at a different way. So we want to treat the person in a holistic way, looking at the entire person. And it helps to treat the person from that physical, emotional, cognitive, and spiritual standpoint. The key elements of treatment, when you think about a comprehensive pain program, is we want it to be evidence-based. We want it to be recovery-friendly. We want to use a minimally effective dose of whatever we are using. It should be an individualized and strategic plan. And then we really want to concentrate on the continued care plan. And the continued care plan is because this is something that people really have to participate in, and it has to be a lifelong process. The idea isn't to eliminate the pain, it's to reduce suffering. So the beginning steps in it from from the person that is suffering with chronic pain, they first do have to realize that change is needed. Very often there are continued attempts to seek a fix, to seek out different providers and sort of hope to be fixed. But really, they have to understand that hey, what they're doing is not working, and they have to be committed to changing the way they think and behave. And then with that comes a willingness to give up the perceived control that they have regarding their pain. And then with guidance, start making the behavioral and cognitive changes that really make a difference. And when you look at these steps in recovery, just the beginning steps in recovery, it's very similar, pretty much exactly to how we look at and treat substance use disorder. So with regard to the physical piece, we want to reduce physical pain as much as we can. We do reduce and wean opioids completely. Opioids over time actually cause something called opioid-induced hyperalgesia, which decreases tolerance for pain. So we want people to be off of opioids. We do use other medication, but I put that at the end of the list. Absolutely, there are medications that can be beneficial. So we want to optimize that medication regimen. And then we look at making sure people continue to be physically active to recondition. We use things like yoga, stretching, acupuncture, massage, and a balancing of overall activities in life. These things are incredibly effective when done well and when done in the right patient. The second is to really address that emotional piece. So whatever might be occurring, whatever symptoms are there, we want to treat. We certainly want to make sure we're addressing trauma, grief, and a potential mood disorder. And again, if there's not a mood disorder present, the symptoms of that mood disorder, we want to support them with empathy and active listening, and utilize motivational interviewing, which is help them get over the ambivalence of that they have regarding their chronic pain. Help them understand from their perspective and learn through thinking it out, so to speak. And then the cognitive piece is really, really important. Some people will say that the education is really the cornerstone. And if people do understand what occurs in chronic pain and how to address it and how to go about recovering from it, they tend to do much, much better. So we do want to have lectures describing what chronic pain is, how to address it, and so forth. Give them some homework. And then, of course, there's cognitive behavioral therapy that we utilize both individually as well as in groups. And that addresses not only the cognitive piece, but also the emotional piece. Really, really important part of a comprehensive pain program. And then from a spiritual perspective, we do want to help give people back the meaning and purpose to their life, help them to regain those identities that might have been lost. And we want patients to sort of make peace with their pain, which will reduce their suffering. Again, it doesn't eliminate the pain, but they can have an incredibly fruitful and meaningful life while managing the pain, so to speak, or recovering from the pain. So things like meditation, particularly mindfulness meditation, in addition to the group therapy. And there are 12-step groups. There's a Chronic Pain Anonymous as well. There's an anonymous for everything pretty much, and there certainly is one for chronic pain as well. And what we're trying to do in the end, just the outcome of this, is we want people to have a greater sense of self-efficacy, how to become active and engaged in their recovery, and how they can take ownership of their own recovery. We want them to understand how pain works in the brain, and that involves both the thinking and the feeling part of it. They have increased distress tolerance. They're managing their emotions better. They have a much better balance in their life and a routine, and they're starting to feel a connection to others, which has been lost over time due to the isolation from the disorder itself. And it is, I think I went maybe a little over, but I said is try to get a lot in there in a fairly short period of time. Again, there's a lot more to learn and understand, but at least that gives a quick overview.
Wow, that was really helpful, and you're actually under your allotted time, so thank you for that. But I'm going to actually follow up with you, if you don't mind, with just a question or two
Sure.
before we move on to Dr. Moriconi. I'm so grateful that you mentioned opioid-induced hyperalgesia, because as you mentioned earlier, there's an awful lot out there right now in the mainstream media with, films and books and all of this. I thought that 2-part HBO series, oh God, what is it? Crime of the Century was really, really well done. But one thing that really frustrated me, they talked a lot with that physician who egregiously overprescribed people whose families were begging him to stop and all that. No one talked about hyperalgesia. Can you explain that a little bit more? I think this is so important for people to understand how pain can be exacerbated by pain medications. Can you just talk a bit more?
Sure. Yeah. I mean, there's some debate about exactly what is going on. And the idea behind opioid-induced hyperalgesia is that when you take opioids persistently over time, you have a decreased tolerance to pain, but really what there's an increased sensitization to pain. So you feel pain more. I actually think some of the studies they're not looking at it the right way. I think that again, it's a process that we don't fully understand. But there's no question that people that take opioids for a period of time have exacerbations of their pain. And then when you are weaning off of it or in between doses, your pain really swings wildly. So you take a dose, you get some relief, and then as that wears off, your pain is much more exacerbated. And then when you are weaning off of opioids, you do have a period of more intense pain. And at about, it's different for different people, but at about 6, 8, 10 weeks, there's a huge reduction in pain. And if you don't do anything else, we talked about the comprehensive recovery program, but if you don't do anything else except for wean opioids, people's pain improves. So that's the idea behind opioid-induced hyperalgesia.
Thank you. That's really, really helpful. And I wondered also if you could talk a little bit about, if you could kind of put on your other hat of running a rehab, if you could talk about what you're seeing with your patient population as far as the trajectory of opioid use disorder and where it is today versus when this was escalating in the last 10 years or so.
Well, it's interesting because we knew when I finished my fellowship in 2006 and my pain fellowship in 2006, we knew at that point that we should be weaning opioids for people with, the non-cancer or benign type of pain, because we saw there weren't studies to support it. It wasn't something that was very productive, and there were a lot of problems that were emerging. So there was still an increase in prescribing, but we knew we probably shouldn't be doing it. When I first came to Ashley in 2009, about 10%, 5 to 10% of the patients admitted were their drug of choice was opioids. When I got back to Ashley in 2016, the number was about 35%. And right now we're seeing about 40%. Now, it can change depending on location. There are some facilities where it's close to 100%. And there's some facilities where it might be a little bit less, but that's been fairly stable for the past 5 or 6 years, but it's really a large, chunk of patients compared to what it used to be. And now you have sort of the cat's out of the bag. You could decrease prescribing dramatically, and you're not necessarily going to decrease opioid abuse for quite some time, because the availability of opioids on the street is high. And there's also some, there seems to be less of a stigma associated with opioids, whether it's oxycodone or morphine or fentanyl or heroin. There isn't the same stigma as there was even 10 or 15 years ago. So I think that the problem's not going anywhere for quite some time, unfortunately.
Right. Thank you very much for that. Okay, great. I'm sure we'll have more questions for you, but actually, can I ask you to stop sharing your screen and then we'll go ahead. Thank you. Perfect. All right. So next we have Dr. Steve Moriconi. Steve is a very dear friend, and I'll just let you know that we honored Steve a year ago, just about, at our annual fundraising event, because he has been such a dear friend to us. He's presented many times when we've talked about opioids over the years, and he is someone who does not come from the world of drug addiction treatment. He's an oral surgeon. He just happens to be a very compassionate person, and I am always eager to hear from you, Steve. So thanks Thanks so much for joining us.
Absolutely. Thank you.
Thank
and I
you.
appreciate the opportunity to talk to you all today. I'm going to come at this from a slightly different standpoint. Dr. Hobelman was talking primarily about chronic pain, as he said right at the beginning of his lecture. And that's a whole world of treatment and an understanding that I tend not to touch on too much when I'm speaking about it, because I come from an acute pain background. And that is because, as an oral surgeon, and I would say probably 98% of the people listening to me right now have had their wisdom teeth out and have been prescribed opioids or given opioids during the course of the treatment for their oral surgery procedure. And I, having been an oral and maxillofacial surgeon for upwards of 40 years and recently retired, have been, right in the throes of that for the past 30 years in terms of prescribing. And so what I became very interested in a few years ago was the fact that dentists and oral surgeons prescribe a lot of opioids for acute pain, because we inflict a lot of what's called nociceptive pain, in other words, tissue damage. So our dental procedures, whether it be surgery or root canal or gum surgery, whatever it may be, all of you know how much pain that can cause. And so therefore, we in dentistry and oral surgery have been at the forefront of prescribing. Back in 2012, dentists were the number 2 prescribers of opioids in the country, only behind internists, primary practice physicians. And so, we have been a huge part of this problem in terms of prescribing. And so, in my own personal practice, I little by little over time, being aware of this problem and having folks come to me in recovery and knowing what I could and couldn't do, reached a point where I started to winnow down the number of pills that I was prescribing for my patients. And so what happened was, over time, I began prescribing less and less. I found that a lot of my patients actually didn't require much in the way of opioid post-surgery pain medication. And so I thought, okay, let me decrease the number of pills that I'm prescribing. So many had pills left over. In fact, we know that up to half of the opioids prescribed at the time of dental visits are excessive. Studies have shown that over 50% of the pills that dentists prescribe go unused. So as of, again, about 10 years ago, that meant somewhere between 50 and 100 million pills left in the population that were not used, that ended up in medicine cabinets. And as Kim talks about, where does the visiting teenager go? Where can they go in your house and lock the door? Right? I mean, it's where your medicine cabinet is, in the bathroom. And so, this was a source of and a cause of a lot of the initial opioid addictions that occurred back in the 90s and 2000s. Also, dentists tend to prescribe too much in an opioid medication, whether it be Percocet or Vicodin or whatever. It was too much. And we also know that certain areas of the country got prescribed more. It tended to happen with young adults. Of course, my patient population was between 16 and 21, which arguably may be the time when folks are most likely to enter into addiction. I tell my audience all the time that it really is the first prescription that a doctor or a dentist writes that could potentially lead down the path to addiction. We know that somewhere around 20% of folks who get prescribed opioids will go on to a substance use disorder. And so we in dentistry are kind of at the beginning of the problem, as it were, of opioid use disorder, simply because we're the ones that are on the forefront of that acute pain. And as Dr. Hobelman said, acute pain can go on to become chronic pain. We know that happens. And it is a significant problem, something that we in dentistry are becoming way more aware of. And so my discussion with dentists is, let's see what we can do to decrease that. Let's get in on the ground level and see if we can lower this. I won't go over this particularly, but this just appeared as research from the Philadelphia Department of Public Health in June this year, that 81% now of overdose deaths involve fentanyl. So yes, fentanyl is a huge problem. It's not so much in my world, again, but it is a problem. And it is a problem partly because it's cheaper. Fentanyl or heroin, particularly on the street, you can buy for $10 a bag. An OxyContin costs $80. It's a matter of what people can afford when they do get out on the street. But again, these are problems that have developed in part because of the prescribing practices of dentists and physicians. Someone asked in the questionnaire earlier in the week about pain as the fifth vital sign. I think it was a nurse who mentioned that she felt duped, by this, that she had been convinced that this was actually real. And in fact, many of us thought that it was. Pain as the fifth vital sign came out in the mid 90s, parenthetically, when OxyContin first came out for pain control. And this fellow who was James Campbell of the American Pain Society, he introduced that phrase. And it was such a catchword, and then became such an institutional thing that we all thought, oh, well, this makes a lot of sense. So we can measure body temperature, blood pressure, heart rate, and respiratory rate. And we can ask the patient about pain. But the problem is, two problems with that. One, and Dr. Hobelman mentioned this, pain is the only one of those five vital signs, as it were, that requires the patient's testimony to measure. And so we can measure the other ones, but we really can't measure pain. It is subjective. It is very different from person to person. It depends on so many things, as was alluded to, genetics, age, social situation, et cetera. And so this was something that we became very much aware of, but didn't know that it was something that was really a marketing ploy. In fact, it was later determined that this American Pain Society received 90% of its funding from drug companies. And so this slowly has gone away. But back in the early 2000s, you've all seen the pain rating scale, 1 to 10, or the faces that you see pasted everywhere. Well, finally, hospitals are starting to get rid of these pain scales. And the reason is that patients actually can manipulate the pain scale so that they can actually obtain more opioids. And I won't go into all the stories about my practice where we've had patients seeking drugs or describing a level of pain that we could not attribute to the surgical insult that we imposed. And so it's a problem that thankfully is slowly going away in terms of us describing it and realizing more. This is something we need to deal with on an individual basis. There's no magic bullet here. When I talk about prescribing for dental pain, that is any kind of pain that's induced by surgery or insult, and that could be trauma too. You could be in a car accident, break your jaw, same idea. And when we talk to our patients about this, I talk on a very basic level. And we're talking wisdom teeth here, okay? Everybody's expecting to walk into my door and be inflicted upon them a tremendous amount of pain. And the way we can help diffuse that is to talk about what we're going to prescribe. And how we do that, I'll mention it briefly. But we put on our actual post-operative sheet that for pain after surgery, you're going to take, for most folks, 3 Advil and an extra strength Tylenol. I don't go into the milligram dosages. It's not necessary. For the average person coming to see me, they just need to know 3 in 1, and that'll work very well. And why is it going to work very well? Because it hits 2 things, Advil and Tylenol, okay? Advil, which is ibuprofen, is an anti-inflammatory, so it'll decrease the inflammation in the tissue. Acetaminophen or Tylenol decreases the temperature of the tissues. And so those 2 things working together, we say they work together synergistically. And so when we prescribe both together in folks who can take them, which is most people, it's going to provide a tremendous amount of pain relief. Now, of course, in my world, I have an advantage. After I put the patient to sleep, and most of them I did, we can give them Novocaine. And the Novocaine that I would use could last up to 12 hours. And so a lot of my folks would wake up and in no pain, most of them in no pain at all, and wouldn't have any pain that whole day. And so when I would sit and talk to those patients ahead of time, I would be able to tell them that and reassure them that you're not going to have any pain when you wake up. You're going to be comfortable throughout the day. And when you finally do have pain, this is what's going to work the best for you. So in that sense, we use the doctor-patient relationship in a positive way to tell the patient that they're going to have a good experience with this, that it's not going to be that painful. There are some caveats to that I'll mention in a second. But again, we have to also be aware of the fact that pain is subjective. Everybody's going to feel it a little differently. Everyone's going to be affected one way or another by it. But I know that this worked because for 30 plus years, I called every single surgical patient, unless I was deathly ill myself, the day after surgery. And I would always ask, had they taken any pain medication? And the general answer was no, or maybe they took 1 or 2 of the narcotics at the time. And so that evolved over time to where, as I said earlier, I stopped prescribing as many as I did and slowly winnowed it down to none at all, with almost like a social experiment in my own practice to see if I could get away with not using any opiates at all. And I can tell you that based on my experience, and I'm not going to toot my horn, but I might have also done some good surgery, less inflicting of pain, as it were, in terms of length of time. That does have something to do with it, post-operative pain. But that so many patients had relief with the combination of Advil and Tylenol that I found it almost unnecessary. And for 3 years, I didn't prescribe a single narcotic in my practice. Many of my dental colleagues don't believe that, but it's absolutely true. And how do we get people to accept that? Well, first of all, I want to step back 1 second and just say, for you folks listening as patients, your doctor is not a saint. Your doctor is not a know-it-all. Your doctor does not have power over you, okay? You have power over your own body, your own pain, your own experience. And you should discuss that with your doctor very carefully prior to any surgical procedure. I don't care if it's wisdom teeth or not. Quick story, I have had several patients in my practice who went to other doctors in different states who needed teeth removed. And were all told, these are folks in recovery, were told that they would need to be put to sleep, given benzodiazepines such as Versed, Valium, et cetera, and then absolutely would be required to take post-operative opioid pain medication. And the couple of patients that I had who were smart enough to realize that it only would take one pill for them to go right backwards, walked away and ended up coming to me, where I could do the procedure with just Novocaine and give them Tylenol, Advil, and they were fine, routinely fine. So I proved to myself that I could do this. But some of it has to do, as I said earlier, with talking to the patient and you talking back to your doctor, sharing the experience. And in my case, having that rapport with the patient in a very quick period of time. Oral surgeons work very fast. You see us for 15 or 20 minutes a week before the surgery, or 2 or whatever it is. We do the procedure, and then you see us for 5 minutes a week later, maybe. And so we don't have a lot of time to develop that rapport. And so it's important to sit down, level with the person you're talking to as a healthcare provider, and make sure you're talking to that patient in terms they can understand. And if you're not getting that from your physician or dentist or doctor, you need to demand it and be your own advocate, or be an advocate for the family member you're with. You don't have to be buffaloed into a treatment or a pain management treatment that is one that you feel might be harmful. And you have the ability to speak up about that. So don't be afraid. We don't bite. So what I often did was I tried to manage the expectations of our patients to say, yes, you're going to have pain. I'm not denying that, but your pain is going to be minimal enough that you can take this medication every 4 to 6 hours and you're going to be fine. However, if you have a problem on the night of surgery, when that Novocaine wears off and you're having trouble, and you find that this Tylenol Advil combination isn't working, you can call me. So you have to be available after hours. And I'll tell you, I probably got one call in the evening, later in the evening, that whole 3 years that I wasn't prescribing. And that person was upset that they felt that they had to call me because I was a nice guy. And so when they felt that they had a little bit too much pain, they took the medicine and they thought, okay, I'm going to accept a little pain, but it's not bad, so I'll get through it. I am under no illusions that we can alleviate all pain. It doesn't happen. So that education, that expectation that we have for folks is that, yeah, it's going to hurt a little bit, but it's not going to be that bad. You don't need a narcotic for it. And I come off very strongly about that, but I do give them an out. And the mere fact of giving the patient an out and an opportunity to contact you later is key. And to me, that's the best way to do it. And it worked. And I proved it in my own practice. So this is what I preach to my dental colleagues around the state of Pennsylvania. This is something that is very, very viable. And if you do it right, and if you spend the time, you can do it well. One of my colleagues says, when you're talking to patients about pain medication, acute pain after surgery, and they're asking you for it, which many did, it takes a half an hour to say no, but 3 seconds to say yes. And, those of us in busy private practices, it's hard to spend that little bit of extra time sometimes. But you need to do it, because look what's happened, when we haven't been doing it as much as I believe we should have. Dr. Hobelman mentioned about the alternative pain management. I won't talk about any of this, except to say the one point I make is that all of these have their place in pain management post-surgery and chronically as well. Part of the problem with them, though, is that so much of it's not covered under insurance. Patients can't afford it. I'm sure Dana can talk to this. It's difficult sometimes to get people to do these kinds of things because they either don't want to or they can't afford it, and so that's a big problem. And until we have some kind of legislative or political will to cover some of these legitimate treatment options, I think we're going to have an uphill battle with a lot of this. So what I tell my dental colleagues when I do this lecture is stop prescribing opiates, period. Don't bother. It isn't necessary. If you have to give anything, and when I did, the one time I gave the person the Tylenol with codeine, I gave him 2 pills to get through the night. And that was it. And if somebody ever called me up a day or 2 later and said, I'm still in pain, this isn't working, I would see them. And you wouldn't believe, having seen that patient 2 or 3 days after surgery, the reassurance that you can give them that what they're experiencing is normal and that it's abating, or maybe it's not. Perhaps they had an infection, whatever it might be. So we deal with it, but we don't just willy-nilly prescribe. And I think that's the way we're going in dentistry. We've made a lot of inroads into decreasing opioid prescription writing to the point, and I'll say here at the end, the most amazing thing that happened to me at the end of this whole period of time in prescribing is 1 week, a young man came back and I asked him how he did. He said, "Oh, I did great. I didn't take any of the pain medicine." And I said, "Wait, I didn't prescribe any pain medicine." I was already still in that old mindset. He was thinking Tylenol and Advil was the pain medicine. What an amazing evolution, right? So I think that's the kind of direction that we need to take in healthcare in terms of acute pain management. I'm not talking about chronic pain. It's a whole different ball of wax, but it is something that we can affect. And as I said, we in dentistry are at the ground level of this. Less so now because of the problems of heroin and fentanyl addiction, but nevertheless, we're at the ground level and we can continue to cut it off before it even starts to grow when we're prescribing like this. So, and we're all together here. And that's why I enjoy spending the time with you folks and being here and telling you a little bit about what I've done and how I've gotten to this point. I certainly never could have done this alone. And I appreciate Kim Porter and your organization. You do an incredible amount of work for folks in the community. And I commend you and on all of you for being here. So I really want to thank you very much for allowing me the opportunity to chat. I could go on, but I want to give you a chance to catch a breath here. Thank you.
Thank you so much, Steve Moriconi. Really, really appreciate you so much. All right, let's move on to our holistic medicine professional. Dana Depaul Ellis is with us. She is an acupuncturist. I think, Steve, you're going to stop sharing your screen. There we go. There we are. Great. So, Dana, would you like to tell us a bit about yourself and jump right in?
Sure. My name is Dana Depaul Ellis, and I am an acupuncturist licensed in the state of Pennsylvania under the State Board of Medicine, and I have a private practice in Bryn Mawr. I am also a chronic pain patient. For many years, I suffer from debilitating and chronic pain. So on a personal note, listening to Dr. Hobelman and Dr. Moriconi speak kind of really brought up a lot of emotion, kind of really touched on that. Dr. Hobelman, just the many aspects of chronic pain. And then Dr. Moriconi just advocating for, just encouraging patients to advocate for themselves when they are at their doctors. And that's part of the reason I was really honored to be asked to speak today, because it's not only an opportunity to share my own personal journey with chronic pain, but to introduce you to acupuncture and traditional Chinese medicine, kind of the way I was introduced to it, by seeking out treatment for chronic pain, and how it can be utilized to treat many common pain conditions, both safely and effectively. I was first introduced to acupuncture when I was about 22 years old. I was living in San Diego, just like carefree, first year of grad school, when I started having really unexplained and pretty severe gynecological issues. I actually stopped getting a period. I was riddled with uterine fibroids, ovarian cyst, and I had debilitating abdominal and pelvic pain. Despite trying several pharmaceutical interventions and seeing many doctors, the symptoms persisted, and the side effects of some of the medications were pretty unbearable. So a friend suggested I see her acupuncturist. Now, I'm a Philly girl born and bred. It was the late 90s. I was, as you can imagine, pretty skeptical, but I was pretty desperate. So I said, okay, I'll give this thing a shot. After my first few treatments, what I now know to be the side effects of acupuncture, which were overall stress reduction, better sleep, improved digestion, they were enough to kind of keep me coming back for more treatment. And over time, what I noticed was a significant reduction in my pelvic pain. I started getting a regular period again. And honestly, what blew my mind the most is that eventually, about a year into regular treatment, there were no more ovarian cysts on the ultrasound, and the number of uterine fibroids were significantly reduced. So I started going a few times a year for maintenance, and then, just went about schooling, my life, and my career for nearly the next decade. Cut to 8 years later, when I was living in Washington, D.C., and I was working with the military, I was traveling about twice a month to active combat areas in Iraq and Afghanistan during the height of the conflict there. I injured my back falling after stepping off of a helicopter, and I again turned to acupuncture and Chinese medicine to manage that pain. I also eventually consulted with several neurosurgeons in the DC area, all of whom were flabbergasted that I was up walking around, let alone flying, traveling, going to yoga, or doing anything with the severity of disc rupture that they saw on my MRI. Eventually, I did decide to have minimally invasive back surgery at age 30. Again, the doctors were amazed at the speed of my recovery and the lack of need for pain medication post-surgery. A combination of pre- and post-surgical treatments, along with gentle stretching, walking, meditation, enabled me to control my pain solely with small doses of ibuprofen and acetaminophen, as Dr. Moriconi pointed out. I was back to work in 4 weeks and back hopping on and off helicopters in 6. It was at this point that I knew I wanted to change my life and that this is what I wanted to do for a living. I quit my job, I sold my house, and I moved back to San Diego to begin a rigorous 4-year, 4,000-hour Master of Science and East Asian Medicine degree, where I began practicing. Ultimately, though, I did know that I wanted to come back home to Pennsylvania and help the communities that I grew up with. Since moving back 7 years ago, I have really seen acupuncture finally gaining traction and credibility in our area, both with patients as well as doctors. I have been seeing more insurance companies over the last few years in Pennsylvania begin to cover acupuncture, and that's really heartening. In California, where I was living, it is covered by every insurance company, and it has been for quite some time. So I'm happy to see us finally getting up to speed here on the East Coast. And I'm always thrilled when a patient's doctor sends them to me and that we're able to collaborate in their care, formulating a truly integrative plan for pain management. Obviously, with the growing national crisis of overprescribing, overuse, and addiction to opioids, that often begins with treatment of pain. I think it's really important now more than ever to explore not just acupuncture, but I also just want to talk briefly about the other often lesser known modalities of traditional Chinese medicine as a first line of treatment for many pain conditions. And also as an alternative treatment for those who are in active recovery and experience pain issues for which they can no longer take pain medications. There's been extensive research over the years conducted on acupuncture, particularly for acute and chronic pain conditions. In 2016, researchers studied outcomes from over 50 years of published controlled clinical trials in the United States, culling evidence of the efficacy and effectiveness and safety of 7 widely used complementary approaches to pain. They evaluated the top 5 pain conditions and commonly treated in primary care settings: back pain, osteoarthritis, headache and migraines, fibromyalgia, and neck pain. Results of the study showed acupuncture to be the most effective complementary modality for osteoarthritic pain, back pain, and knee pain. In another series of experiments, researchers found proper placement of fine acupuncture needles at certain acupoints of the body allowed subjects to tolerate greater amounts of pain. MRI imaging of the brain before and after the acupuncture treatments showed a dramatic 70% decrease in activity in the areas of the brain that regulate pain while the acupuncture was being performed. This is why the National Institute of Health concluded acupuncture to be an effective treatment for many pain conditions, and why it continues to be widely studied in order to reduce and in many cases eliminate the need for opioid prescriptions. So what exactly is acupuncture? How does it work? Acupuncture is just one modality in a system of traditional Chinese medicine practiced for 5,000 years. Traditional Chinese medicine also includes the modalities of Tui-Na massage, herbal and nutritional recommendations, moxibustion, in which certain herbs are like packed into this little like stick or cigar looking thing and warmed around certain acupoints or areas of the body in order to reduce pain and inflammation, as well as cupping and gua sha, which uses a tool, Judy's one of this tool, to scrape, what I would call it, to scrape or myofascial release certain areas, certain muscles, which is quite effective in reducing pain, especially back and neck pain. But getting back to acupuncture in particular, it's when specific acupoints on the body are stimulated, most often by inserting thin, painless needles through the skin. When pressed or punctured, these acupoints have beneficial effects for certain ailments. Now, there are over 300 acupoints on the body. So how do I select certain acupoints for a pain treatment? The beauty of the medicine really to me is that I may have 10 different people come in a certain day with low back pain, and I may treat all 10 of those people differently. So there's no one set protocol. Chinese medicine is a whole body medicine, and it treats the mind, the body, and the spirit. It's a complete system of medicine. And so in speaking with the patient, doing a physical exam, I basically come up with a complete Chinese medical diagnosis. And that is how we select the acupoints for that treatment. And that's really the crux of what I love most about acupuncture, right? Is that I can offer my patients individualized care, and I can often utilize several different techniques to come at pain from many different ways, treating it locally, but also through the whole body and systemically as well. Acupoints can be utilized at a specific site of pain where I might perform muscular or motor point needling. A motor point is a location where the motor branch of a nerve enters a muscle belly. I can stimulate the needle at these locations manually, like I've got a needle in my hand right now in a muscle belly. And so I can stimulate it manually to elicit the muscle to jump. I can also hook it up to this like nifty like jumper cables, right? I can hook it up to an electrical stimulation machine, and I can kind of give it even a little more of a boost, right? And so what happens when I stimulate that motor point is that it sends a nerve signal to the brain to release beta endorphins. And what are beta endorphins? They're chemicals that work as the body's own opioids, lowering pain thresholds. There's also a ton of mounting evidence that stimulating the vagus nerve, which runs from the brainstem to the colon, may lower inflammation throughout the body. As inflammation is closely tied to chronic pain, including points that stimulate this nerve is an important part of my pain treatments. In addition to that, overall, there are just many points on the body and techniques that help relax the nervous system, reduce overall stress and anxiety, all things that also contribute to increased pain levels. I want to talk a minute for protocols involving the ear. There's also something called auricular acupuncture or ear acupuncture. And these protocols can be used totally alone or within an overall full body treatment. And I'm going to just show you here. The ear has its own system. It's got a ton of acupuncture points in it, right? The ear is complex and that is highly innervated on its own, and it has nervous input at multiple levels. So it's unique in that way, in that it has many points for pain, detoxification, and regulating the nervous and endocrine system. So, you know, there's a protocol of 5 needles in the ear that are utilized in this way. Ear treatment alone can be very effective, and it can be used to treat many people in a short time frame, which is why auricular protocols are commonly used by many detox facilities, hospitals, community clinics, as well as by the US military in the treatment for pain and addiction. I also use ear points in every treatment, and often I send patients home with something called an Acute, right? And I don't know if you can see here in the ear, you probably can't. It looks like a little round Band-Aid. And on the other side of it is actually a tiny, tiny baby acupuncture needle. So they can leave with Acutacs, and that will allow the treatment to continue working at home. Sometimes people will just pop on in and just have me place the Acutacs before a stressful event, a dental or surgical procedure, or a physical activity that might aggravate or flare up their pain. A big question I get is how long does acupuncture last? How many treatments will I need? And the answer is that it depends. And that's the challenge, I think, as Dr. Moriconi pointed out, right? It can be costly. Insurance, it doesn't always pick it up. And as with most things, it's not a one-hit wonder. It's a gentle treatment with a cumulative effect. So for most people with chronic and long-standing pain, it's going to take a little longer with more frequent treatment in the beginning to get to that maintenance point. And this can obviously sometimes provide a challenge for patients who may be used to getting immediate relief from a drug. So I find it's really important to work with my patients and meeting them where they are in their journey without judgment, and to set realistic expectations and goals for treatment. For someone with a singular acute, a fairly new issue, say a sprained ankle, we can usually see significant results in just after several treatments. I also see patients pre and post surgery, dental procedures, as well as prepping for childbirth to reduce or eliminate the need for pain meds. I could really go on and on about all of the ways that Chinese medicine can be used to treat pain and overall health in general, but I wanted to wrap up today on a personal note and just touch upon a theme that keeps coming up in my treatment space with many of my patients in regards to their chronic pain. And that's this idea of pain being both normalized and minimized. I think many of us, but women especially, have been conditioned to believe a certain amount of pain is normal and that we should just push through it or suffer silently. It's like when I ask my menstruating patients if they have period pain, and they respond with, oh, just the normal amount. And I have to often be the first one to tell them that that's not normal. There's plenty of research out there that tells us that women's pain is often taken less seriously in ERs and doctors' offices. And I see many women at the end of their ropes with debilitating chronic pain conditions like autoimmune arthritis, fibromyalgia, or endometriosis, which affects 1 out of 7 women, yet takes on average 8 years to receive accurate diagnosis and appropriate treatment. The normalization and minimization of painful symptoms is a huge issue and often significantly delays accurate diagnosis and early intervention for pain. Take it from me, when you're suffering for a decade with debilitating pain that is being continually dismissed, the underlying cause of which is never appropriately addressed, you can become desperate to get relief any way you can. As death rates among women by opioid overdose continue to rise, I think it's really important for us as practitioners to start dialoguing openly and honestly about these issues and challenges, and hopefully start to see pain not as a baseline or a vital sign, but rather a symptom that's trying to send us a very important message about what's going on in the body. Instead of shutting that message down or covering it up, to really listen, dig a little deeper to the root, and provide healthier and safer options like acupuncture as a first line of treatment.
Thank you so much, Dana. That was really interesting. So appreciate you being with us. All right. So, what I love about this organization is we get to work with people who have a personal story of recovery. And in our person in recovery tonight is our good friend, Sean Rogers, who, anytime we have someone who's willing to be transparent about their journey, we are just so deeply grateful. So Sean, I'll let you pick it up from here. Thank you.
Thank you so much, Kim. And thank you to Kim and Judy and all the people behind putting these, virtual events together, in-person events together. And to our panelists tonight, I was going to talk about some stuff in my head that I thought was going to be appropriate for this, which it probably was, but you brought up so much that kind of keyed in on things throughout my story that I want to talk about now. So Dr. Moriconi, I mean, you basically told a big part of my story as how it unfolded, and I'll get into that a little bit. And Dr. Hobelman, thank you so much for talking about the progression of this disease, not only in individuals, but over the years with the overprescribing, because I am definitely an individual at the age of 36 who went through the overprescribing movement. And it was easier during my high school years to get oxys or roxys than it was to get a case of beer. And, it's just really, I didn't learn a lot of this until I became a person in long-term recovery and started to work in this industry. But knowing what I know now about 1998, 1999, the overprescribing boom kind of starting, it makes so much sense that during the 2000s, it was so easily accessible to get Oxy 80s and Percocets on the street. And that's a big part of what led me down the path and the journey that I'm on. So real quick, my name's Sean Rogers. I'm a person in long-term recovery. And what that means for me is that I haven't had a drink or a drug since December 27th of 2011. I had a very loving family. I grew up in, just the short version of my story. I had everything that I needed to succeed. I had two amazing parents at home that worked long and hard for all 5 kids to be able to do the things that we did. And never once did I ever grow up thinking that I want to be a heroin addict. I wanted to be a lawyer. I wanted to be a doctor. I wanted to be all the things that other people, aspire to be, and had no idea what was ahead of me. And, for me, my drinking and my partying was in excess throughout high school and into college. But nothing really got out of hand until I had an injury. When I was 23 years of age in 2008, I tore my lateral tendon in my ankle, and I was prescribed opiates. And, it was my first introduction to any type of opiates. And it really kind of took me down this road and took me on this journey that over the next 3 years, things were kind of a blur. And what took place and what happened was exactly what we talked about tonight was, I was asked in an emergency room very quickly, like what my pain was. And for me, it was a 10 out of 10. It was the most pain I had ever experienced in my life. And, I was given a pretty significant prescription, and I took that home with me, and I refilled that until I could no longer refill that. And very quickly I was addicted. And then it became a matter of seeking and searching for those pain meds on the street until when I was 26, I entered into my first treatment. And, I went to treatment very successfully, 38 days, got out of treatment and continued to stay clean and sober throughout that summer. And to Dr. Moriconi's point, I wish I would have met you because I had surgery done on two wisdom teeth that were never taken out when I was a teen. And I had this consult appointment with my dentist, and he had asked, questions, very important questions. And I had shared some information with him about how I had just went to treatment and I was in recovery, and this was important to me. And, he gave me the referral out to an oral surgeon to take these 2 wisdom teeth out. And when I got there, we didn't really discuss much. It was, a quick look and, okay, we're good to go. And you're going to come back, on this date, and we're going to do the surgery. And my assumption was that information was passed along. And what took place during that appointment was I had the oral surgery done. I was coming up on about 90 days from the day I had entered treatment. And I left that practice with a small grocery bag full of pain meds. And, when I got home, the pain started to wear off, and I started to take those. And I went on a pretty hard relapse for the next couple of weeks. And, even to the point where this facility had filled them for me as well, refilled them, I should say, when I called about 3 to 5 days later. I forget the exact time frame, but it was less than a week later. And all I had to do was show up, and they refilled the prescription. So, for me, that's a big part of my story that led me on a path of another 3 or 4 months run. Things that I'm fortunate and blessed to do is have a lot of conversations with families today, because I also work in treatment. And I always say to families, for me, turning to heroin had nothing to do with, wanting to do heroin. It was purely a financial decision. I could no longer afford to get these pain pills on the street. I had to turn to heroin as a financial decision for me. And on that second run, on that second time out, I did turn to heroin, and it led me down a path where I had lost everything. And in December of 2011, I re-entered treatment. And luckily for me, I was given a wonderful and awesome opportunity to go into a long-term extended care program post-treatment, which was just simply a recovery house in Levittown, to be honest with you. But for me, that was long-term and extended care. And I stayed in that house for 18 months and really kind of grew up in recovery in 2011 going into 2012. And, I'm definitely lucky. I know I'm lucky that I kind of was connected in that way and given an opportunity to go into that program and then get close to a 12-step fellowship. But I also want to share something on the back end of that, right? Because in 2020, I had to have another surgery done for a bone graft and a molar in the back of my mouth that had to also be removed as a direct result of some of the things that had happened prior to me getting clean and sober. And I had a wonderful oral surgeon who I sat down, and just like you described, Dr. Moriconi, we had a full consult, and I let him know how important recovery was to me. And I let him know that I really put this surgery off in my recovery as a direct result of being afraid of not only the pain, but, relapse, because I had shared part of that story with him about the oral surgeon I had seen in 2011. And this gentleman in the practice, they were so kind and they were so considerate, and they understood exactly what that meant for me. And he did exactly as you had described, the 3-in-1. That was his method as well. And they talked about how they really are trying to get away from prescribing opiates and really trying to direct most pain through that process of extra strength Advil and ibuprofen. And I was fortunate enough that I think he was a great surgeon. I didn't have much pain, and I barely ever even used the ibuprofen or the Advil post-surgery. And but it was really comforting to know that doctor was educated and understood, and he was aware of how important that was to me. And you brought that out in me tonight. I wasn't even going to even talk about that, but that's so important, right? So really, we do have a voice. We have a voice to talk to our prescribing physicians and really let them know, it's important to us if we are in recovery or, we want to avoid those opiates, even if we're not in recovery, to have that conversation and to educate and to inform them about where we stand on that. And I also want to touch on another random point. In 2015, 4 or 5 years into recovery, I was lifting a couch at Kim's old office. Actually, we were doing some moving around. And unfortunately, I was on the clock for my work, and I woke up the next morning. I was debilitated. I couldn't move. I threw something out my lower back, and it became a big thing. I didn't want to make it a big thing, but they made me fill this paperwork out, and I had to go see someone because it could have been a workers' comp claim. And this doc was really pushing me to do these muscle relaxers, and I finally had to close the door in his office and say, "Hey, listen, I'm in recovery, and that's just not comfortable for me." And oddly enough, this doctor turned to me and goes, "Oh, I'm in recovery too, like 5-6 years." And I was like, "Oh, that's great. So you understand like where I'm coming from." But, it is really important that we stand our ground, because I have that same fear as a person in long-term recovery, that it could be an injury, it could be a knee surgery, it could be a hip surgery, it could be something that I get these pills and I really get taken out by it. And I've seen so many of my fellows in recovery have that happen and not talk about it and not make others around them aware of that and have gone out as a direct result. So I think this conversation is extremely important. I think this event is awesome for the individuals who get to witness this and listen to our prior panelists. And, for me, it's really close to my heart. And I think one of the questions that came in prior to this event was really based around how do we continue to destigmatize, individuals, and people not only in recovery, but, opiate abusers who are trying to seek help. Right. And I always think it's important. And I say this to Kim and Judy when we talk all the time, is that, I think when you turn on the news, you hear a lot about the opioid epidemic or heroin users or, Kensington. But it's really important. And I can't tell you how much I'm honored, and I respect Kim and Judy so much for always including a person in long-term recovery, because we don't hear about the stories of success. We don't hear about the individuals who, go on to get their lives together and really, transform into individuals that empower others to do great things, right? As we sit here tonight, 10 years ago tonight, I was homeless. I didn't have anywhere to go, and I didn't know what my life was going to look like. And, as a direct result of asking for help and letting people know I was struggling and, walking through that pain with others that were there for me and are there for others. I was able to get my life together. I was able to, maintain a career that I love. I get to do things that don't even feel like work on a daily basis, which is talk to families about their struggles with mental health and substance abuse. And, I even 2 years ago became certified as an interventionist, and now I'm starting to do family coaching and work on such a different level that I never could have imagined, prior to getting clean and sober. So I'm grateful to be here tonight. I feel like I just rambled and was all over the place, but I hope somebody got something out of that. And I thank our panelists for really helping me to realize how important it is to have these conversations with our prescribing physicians and how important it is to talk about recovery as a whole so we can continue to bust stigma and help communities to grow.
Wow, Sean, that was amazing. Can it be said, please, that I did not make you move that couch? That had nothing to do with it.
No, you didn't make me. No, I only said that because it was your office. And
I know.
You were moving stuff around. Me and Kim used to share space when I worked for Center for Families. And I felt so bad. I didn't even want to report it. And our good friend Caroline was like, you have to report it. You did it during work.
Oh, thank you, Sean. You said so many important things. I'm really, really grateful to you. I want to get to something. Steve, you want to say something? I figured you might want to say something, Sean. Go ahead.
Yeah, well, get to Sean and everyone. Well, first of all, Sean, congratulations and well done. I have an idea of how hard it is what you did. And I apologize on the part of oral surgeons everywhere for your experiences. Not that I can actually do that, but you brought out an absolutely spot on problem, and stigma is part of the problem. And it's not just stigma that the community or that those of us who are not in recovery have towards those who either are or in recovery or who are currently struggling with addiction. It's those who are in recovery and or addicted themselves who already feel the stigma and don't disclose. So it sounded kind of like to me that at the beginning, your first experience, you disclosed to the dentist, but of course he didn't communicate that to the oral surgeon, and you just assumed the oral surgeon would know. And I'm no fault of yours, but obviously he didn't. And so he went ahead and did whatever he was going to do, unbeknownst to him. That said, there was a period of time some years back where we actually thought, in dentistry anyway, that, well, yeah, so what, you're in recovery. You can have a couple of pills. You're going to need it. Go ahead. Don't worry about it. You'll be fine. And, that was brought home to me very, very succinctly in the last few years by a man. Brief story, came into my office, sat down. He said, "Doctor, I'm here because I know that what I need to have done, you do the best. And so I'm sitting here. But I have to tell you that some years ago, you saw my son, who was a teenager. He needed his wisdom teeth out. And he disclosed to you that he was in recovery. Nevertheless, you put him to sleep and you gave him a narcotic prescription after surgery. And he took the prescription, and he said, and 2 years later, he died of an opioid overdose. And needless to say, I pretty much just about burst into tears at that moment, because of course I felt instantly responsible for that. And the father was quick to say, yes, we were upset, but I can tell you, we don't blame you, because it was really my son who took that prescription and went to the pharmacy and got that filled. Yes, you were misguided, but he was the one that made the action that made that happen. I said, well, okay, didn't make me feel a whole lot better, but it speaks to the stigma that often people don't disclose enough. And that's a problem for those of us in healthcare too. Don't assume that we know, because we don't necessarily. And having that discussion is hard, because it's, for some, it's part of the stigma is you're admitting to what people perceive to be a moral failing. Well, it's not. It's a disease you had. It's like diabetes or high blood pressure. It's okay. And I think I think it was Dr. Hobelman who said something to the effect of, opioids are becoming less and less of like a thing anymore. It's not so much it's becoming less interesting. Well, it isn't. And in fact, it's very important to be able to talk about these things honestly with your healthcare practitioners. And I hope that's one of the things that I'm doing, is trying to demystify that among my colleagues so that we can have these discussions and avoid these problems, going forward in the future. And Kim, I'm going to answer a question that's already on the Q&A, if you don't mind, about what to do with a patient,
so
a
the
parent
question
whose
is,
child needs their a parent whose child needs
any
their wisdom
suggestion
teeth out. Yeah.
for
And
a
they're
parent
actively
whose child
using.
needs? Go ahead. Sorry.
I'm sorry. They're actively using and they have a low tolerance for pain. So yeah, that's a challenge. And it's a challenge because, I've talked about treating patients who are in recovery and not giving them opioids. Well, what if we have someone who is actively using? Well, Dr. Hobelman mentioned about opioid-induced hyperalgesia. Well, that'd be a problem with a patient like that, because it's going to be very difficult to treat their post-operative pain, certainly not with opioids. So right away, that would be a candidate for the nonsteroidals, the Tylenol Advil combination, in combination, obviously, with a lot of talk and reassurance that they'll get through that. And of course, using the long-acting Novocaine. The problem would be if that patient needs to go to sleep. So I would send that patient up to Dr. Hobelman in the anesthesia unit and let him put them to sleep and use whatever drugs they might feel appropriate. I don't know, Greg, how would you? I mean, I used ketamine and Versed all the time. That was like my go-to. I don't even know what else I would use in an office setting to sedate somebody who was actively using. So maybe you could address that.
From an anesthetic standpoint, in and of itself, I think ketamine and Versed would be fine. Ketamine, if you could do it alone, would be better, because Versed could be triggering to some extent as well. Ketamine doesn't seem to have that same effect. If you can use propofol, that would be the way to go for just the anesthetic itself. It's if you can utilize that, you can do anything. But it does really take two people to utilize propofol from an anesthetic standpoint, because patients stop breathing, and you have to monitor their airway.
Yeah, that's why I sent him to you. Because
yeah. And I had surgery myself, and I went and talked to the surgeon. I said, I'm in recovery. I don't want any opioids. And then I knew the anesthesiologist. So I said, I don't want any opioids. So I did have a surgery. It was a bicep tendon repair. And there were no opioids, and I had a block, and there was no Versed or no benzodiazepines for the surgery. He still gave me a prescription for 60 Percocet. 60. So when we talk about, the need to be an advocate for ourselves, and, and I said, look, my follow-up appointment, and by the way, Tylenol and ibuprofen together, so glad you mentioned that, because it really is potent, and it is so effective. I didn't even come close to thinking about needing an opioid for that surgery. Yeah. And I went back and I said, look, everything was fantastic, but there's no need to prescribe 60 Percocet for this. I didn't even see it. I said, you can, give a prescription to my wife if you want. If I can't sleep, maybe as a rescue. Didn't even think about it. But when I looked at it, I said, you got to be kidding me, 60. So really, we do have to be advocates for ourselves, as across the board. And providers just don't know. I didn't know anything about addiction before I experienced it myself and learned about it, and I saw something going on with patients that had chronic debilitating pain. And some of those do develop substance use disorders, but I just didn't have the knowledge base. And so many providers just don't. We've learned a tremendous amount from dentistry with regard to analgesia and postoperative pain. I think that was really the first place where we started seeing this combination of ibuprofen and Tylenol and how effective it is comparatively. And we can change the way we talk about pain in general. We don't have to say, I need an opioid. I can't tolerate my pain, because to a large degree, there are ways to tolerate pain. Opioids are never needed. At times they can be beneficial and can be used when appropriate, but if you are going to prescribe an opiate to a patient, it better be responsible for what occurs afterwards.
And,
wow.
And just real quickly, I think one of our untapped needs is the counseling and discussion among emergency room physicians and units nationwide. Way too many people go, and because of the nature of an emergency room, way too many opioids are prescribed out of that too. And I'm not aware of much work going on there, but I do see that as a huge problem nationwide.
Agree. And it's a varying degrees of how they're dealing with that. A lot of emergency rooms are doing a pretty good job. And if anything, they're giving 1 or 2 pills, and that's that. But you're still seeing a good amount of prescribing and a good amount of high dose IV use of, Dilaudid and stuff, which causes such a good degree of euphoria that some people, after that first injection in an emergency room, say, I want to seek that, continuously.
Yeah.
Yeah, one other thing just to add to that is there are some emergency rooms and some healthcare systems in our area that actually have stopped prescribing opiates in the emergency room. There was a big to-do about it last year when the Prospect Group through Crozier Keystone Health actually came out and said that they would no longer prescribe opiates in their emergency room because too many people were trying to come and pain seek or seek different pain meds through different experiences they were having.
Good.
Yeah, and John, as you mentioned, that worsens the stigma as well, because people in the emergency room and in hospitals are often seeing people not at their best in active addiction. And they're talking about, an addict or what addicts do and so forth, instead of talking, thinking about the recovery process and how to, provide support for that person.
Yeah. I had a cool experience the other day, and I'm sorry, I didn't mean to but I was at I won't mention what hospital, but one of the nurses said, so you help all those crazy addicts get into treatment. And I said, yeah, I'm one of them. Actually, I'm a person in long-term recovery. And we had like a 15-minute conversation around recovery. And I felt so good leaving there because I felt like it gave her a face to somebody who was one of those crazies in her emergency room, but, was doing something with her. You know what I mean? So again, it's just, I think that continuance of where I see the opportunity to bust stigma, we do so and not feel shame about it. But to Dr. Moriconi's point, in early recovery, I felt very shameful about talking about my recovery. It took me a good, this wasn't something that happened for me overnight. It took me probably 3 or 4 years before I was very open about my recovery. And I got to watch others that became open about the recovery and the effects that they were having on their community. And it really inspired me to do the same.
Good.
Wow. This could be such a longer conversation. There's so much to unpack with emergency rooms and all of that. But I do want to get to this one. We're almost out of time, but I wanted to get to this question for Dr. Hobelman. For the audience, I work on an inpatient psychiatric unit with a lot of patients who have chronic and debilitating pain. Due to this, he's chronically suicidal due to constant pain and struggles to cope. What is your most effective way to treat pain in an acute short-term setting? A specific patient has a rod in his back, severe pain due to bone deterioration from long-term prednisone use to treat Crohn's disease. And also, does your facility take Medicare?
Okay. So first, our facility doesn't take Medicare, but we do have ways of getting treatment for people who need it. And there are other inpatient units that are very effective. Johns Hopkins has one, the Meyer 6 program. So it's something to look into. That question starts with an assessment. So understanding the nature of the pain. Sometimes you have acute pain on chronic pain. There are times for short term, depending on what the nature of the injury or problem is. I'm not saying that opioids are never warranted. They are at times, but really assessing that to make sure. Now, there are a lot of other medications that can be utilized, but I really think that it starts with a conversation, and the conversation is sitting down, listening to that person, helping to teach them, as I had stated, some people think that the cornerstone of the treatment of chronic debilitating pain, like those patients have, is an understanding of what's going on. So really sitting down, listening, giving time, as Dr. Moriconi was saying, it's so important to actually hear people and to listen, and then you can start having a conversation about ways to manage the pain. But there are a lot of other things to do on the unit. There are other medications that are not habit forming that can be prescribed. There are physical things that can be done on a unit. There's heat and ice and so forth. So there are a lot of actual interventions that you can turn towards before opioids, and then looking into programs to continue the person's recovery from chronic pain over time. They're very difficult cases, and until that person has a mindset like they've got to change the way they're addressing the pain, they're not really going to get that much better. So you have to sit and talk to them.
Thank you so much. I have so many other things I want to talk to you about, but we do have to go because it's already at 8:32. I cannot thank you all enough. We're going to have a follow-up page. It's that conversation.zone/opioid here. I'm putting it in the chat for you all right now. The recording of this program will be loaded there probably overnight, sometime tonight. I've got to process it and get it loaded onto YouTube, but it will definitely be there by morning. We have lots of other resources on that page and contact information. I know some of you have asked to reach out to some of our panelists. That is available along with their bios and PowerPoints. Oh, and Dr. Moriconi, if you can send me your PowerPoint as well. I think I already have Dr. Hobelman. So thank you all so very much. This has been really, really helpful and just terrific information. Can't thank you all enough. Thanks for being with us, everybody.
Thanks.
Thank you.
Thank you.